true pleasure to introduce Professor Eric Wilson. He's very well known, but you should know that he's a professor of surgery at University of Texas, and he's also director of bariatric surgery, chief of bariatric surgery in Houston. Eric is a leader in bariatric surgery, leader in robotic surgery. He's very well known and respected worldwide. I think that no one has done more bariatric surgery trials than Eric, robotic, laparoscopic, and endoscopic. So I happen to always spend great time with Eric, and we were together in Argentina in an amazing meeting, and we have a lot of fun. So Eric, it's a pleasure having you here.
Thank you, Santi. I really appreciate it. That was a very nice introduction. As usual, a little more than deserved, but I appreciate it. Let me share here and make sure everyone can see. Does that look like everyone can see it well, Santi? Thank you. Thanks, Santi. All right. So I'm a little bit of a poser today. I have done a lot of robotic surgery for 20 plus years. But when it comes to robotic systems, I've done a lot of work outside the United States with multiple companies on this, but no modular arm system currently is FDA approved in the United States. So the volume of clinical cases I have are very, very minimal. Have done a decent amount of lab work and other types of work, and have been fortunate enough to hang out with, for example, Paula and several other folks around the world as they do modular arm robotic surgery, but it's not approved in the USA. So I don't have quite the experience that Pradeep and Paula have. So certainly that's my biggest disclosure. Take that with a grain of salt about what I say. But I'm going to talk a little bit about use of robotic arm systems in foregut surgery with lap chole. And, I think it's an interesting concept to kind of talk about the evolution of robotic platforms and where we've come from without spending a lot of time doing that. But if you look at the history of, our major player in soft tissue robotics, it's been the intuitive Da Vinci platforms, and there's been 4 generations. And as it relates to how these platforms work from a patient-facing side, they're all boom-mounted systems. It's a boom-mounted system. It's been 4 generations of boom-mounted systems. Probably will be a next generation will be a boom-mounted system unless something changes. Intuitive has gotten very used to that. So boom-mounted arms, just as a contrast, they're one surgical cart to move. Their external interferences are managed mostly physically, with not having to do a whole bunch of software management, because you don't have to have a lot of software recognition in the arms' relation to each other. If you have one arm down, and some of us have experienced this, although the system is quite reliable, you can't really swap it out. So you have to just not use it, or you have to change the case. It's limited to multi-quadrant access based upon its design, although the size of the arms have played a role. And if you go through the generations of the intuitive systems, what you see is these arms have gotten smaller in profile, even though their strength has stayed pretty long. But they have to be quite large for the stability, and they tend to have a big footprint. And so that's one of the reasons that people talk about modular based systems. And so you know what it looks like when we put a boom mounted system. You have basically one boom you have to deal with, but you've got to roll in a fairly large platform to do this. What about mounting it off the ceiling? So the boom could be off the roof. But then you've got a robot mounted and dedicated to that OR, and you can't move it around. And I think this is an intuitive prototype of doing that, and basically they have not ever pursued it. Contrast to that is table-mounted arm systems, and these are in development, but no table-mounted system is widely being used, where the robot itself, as far as the patient-facing side of it, is the table. But that's being developed. Obviously, Auris and Verb Surgical, which are both J&J systems, have been working on this for a long time with an open surgical cart, potential endoluminal approaches in addition to laparoscopic approaches. This allows potential integration for what we call combined endoluminal laparoscopic surgery, although you could do that with other systems as well. So there's no surgical cart to move with a table-mounted system. The external interferences can be physically managed But you can also have pretty elegant software management, potentially to manage external interferences by managing the arms in relation to each other. You can't really swap it out because it's part of the table. So, you know, if the robot has a problem, it's even actually a little bit more challenging than even a boom mounted system, because, you know, you have to move the patient to another table if you're going to change robots. So there potentially can be less limitations on multi-quadrant access, but it also gets down to the size of the actual arms themselves. And you potentially don't have to have the system quite as large for stability. And you have a smaller footprint, obviously, because the footprint's basically the bed. That being said, none of these systems are currently out in clinical practice. So this is kind of an, you know, a cartoon of how a table-mounted system could look, with potentially 4, 5, 3, 4, 5, or 6 arms. So when we come to the modular systems, we've had players in the market for a while. Asensus is the first modular system. It's just extremely large modular system and has approval inside and outside the United States, but it is a very large system. It's an open based console and instruments that could be 3 or 4 arms, and small instruments like 3mm instruments, but not always wristed, and long instrument lives. Asensus is, you know, through COVID is still out there, and you'll see them, but still working on growing. And then, of course, we have the Medtronic system, which is the Hugo system, which is in current FDA trials right now, particularly in urology, an open surgical cart, modular 3 to 4 arms. Most of the times the systems are going to be sold with 4 arms, but you can use 3 or 4, a full complement of the wristed instruments, and a cost-focused analysis. There's several other modular systems out there in addition to kind of our main player that we're going to talk about today, the CMR system. But CMR has the largest volume outside the United States and is growing the most quickly at this current time. So, you know, with a modular system, the nice thing about it is you can start with 3 modules, you can add a 4th, you can potentially even add a 5th, possibly more. And that kind of gets to the CMR, Cambridge Medical Robotics system, which we'll be talking most about today. And it's a relatively small footprint, modular based, 3 to 5 arms, designed to mimic the human arm. And approximately 10,000 cases have been done clinically now. So quite a bit of volume, although it's not FDA approved, much to my chagrin. I'd love to be figuring out how to utilize this system effectively in my patient population in the United States, and hopefully we'll get there soon. The open-based system allows you to stand and sit. This is the only video of mine that I can actually show you, showing doing a gallbladder and doing a pretty large paraesophageal hernia, but this is in a cadaver. This is not a live patient. So obviously you can do a very similar type dissection with this system as you would with any other robotics platform or laparoscopic platform. And you can see this hiatal hernia was quite large that we were closing down as we were doing this case. So it was kind of fortuitous that we had a cadaver that just had a very large paraesophageal hernia that we dissected out and closed. So the clinical cases I have today are from Dr. Simon Higgs. So I appreciate his ability and desire and gratitude in giving us these cases to look at. But we've got a laparoscopic cholecystectomy in the upper left, and a hiatal hernia repair with a Nissen fundoplication in the right. You can see in this situation, we're using 3 arms, a camera, and 2 working arms with wristed instruments on both sides, hook cautery on the left side for the gallbladder, which is a common way to dissect the gallbladder out. When we do clips for the gallbladder, we are using external clips through an accessory port. So for a learning case, obviously this is a good case. I've done many lab cases with gallbladders using the CMR system. I think it's a great way to get adept to the platform, deal with basic docking. As you add more modules, you have to get more creative. And I think Pradeep and Paula will talk about placement of the arms as you add more arms to them, because 3 arms are easier to learn than 4, and you've got to learn your angles of approach and attack. But then you also usually have an assistant port that you need access to things as well. And so a lot of cases have gone to forearms. You can certainly do a forearm gallbladder and a forearm hiatal hernia repair and repair the crura as well as a wrap. Let me fast forward a little bit here to show mobilization of the greater curvature. When you're mobilizing the greater curvature, in this situation, we don't have advanced instrumentation yet. They're working on that very earnestly. And so bipolar ligation of the greater curvature vessels and then division with monopolar scissors is the way that Dr. Higgs manages this. I think Pradeep and Paula can talk about how they do vessel ligation as well, but I think bipolar and monopolar scissors. But we do have advanced instrumentation around advanced energy coming pretty quickly. So you can see typical hiatal closure and then performing a wrap, and I'll fast forward to that to see a Nissen fundoplication in a pretty standard manner. So modular arms allow multiple surgical carts to move in and out. You need more complex software recognition of the arms in relation to each other because the modules are independent of each other, and that's important for external interference management. The pivot point remote center management can vary with the types of arms. For example, the CMR system actually has a software managed pivot point, which actually could be less traumatic if you're off the pivot point and the software can adjust for that. And I think CMR's done a lot of work to optimize that. And that's some complex software, but they've gone through that process and made that, I think, better. And so I think that's an interesting advantage that we should talk about more. One arm's down, you can swap out with another module. So that's really nice as it relates to modular systems. I think there are potentially fewer limitations of multi-quadrant access. Of course, you still have to consider the profile of the arm itself, and the profiles are quite low or small with the CMR system, but you can still have external interferences based upon your setup. And the footprint depends upon the module. So these smaller modules that CMR has have a smaller footprint and allow for more flexibility, but possibly less strength. The question then becomes is how small can you make the module to hold a good support and still have strong strength to manage higher BMI patients? And I think that's something that we need to look at, because some of these modules will be larger, but possibly have more strength. So the big areas of debate as it relates to these different types of platforms and the modular systems are, how do you access things during emergency situations? Luckily, that doesn't happen very often with good management. But with a modular platform, it's actually pretty easy to get in there. Setup and docking, those have various challenges and advantages. What's the easiest? I think that's something we still have to discuss and learn as we get better with these types of robots. And then the interference management and what feeds back to the surgeon on the console with what type of haptic sensation you get with an external interference or an internal interference. And then the flexibility of the modules versus the footprint and the strength versus the size. So, what works best? We don't really know yet, but it's an exciting time to see how these are evolving. And there's a lot of factors that are in play: the case type, advanced instrumentation development, which is coming in a lot of these new systems, and then digital analysis options, which is way beyond the scope of this talk, but there's a whole bunch of additional things that can be measured off of robotics that all of these platforms are going to be looking at, and they'll be offering different types of approaches to that. So I'm really excited about the next 5 years to see how much these systems kind of expose themselves as far as what they're really good at and what some of the challenges are. And obviously, I'm curious to see what platform gets us to allow us to have 5 or even 6 arms or combined arm usage endoscopically and laparoscopically. And I would say we don't use one operation for any given surgical disease. We've got multiple operations for reflux, for example, multiple operations for bariatric surgery. So why would we use one robot? And I think these different approaches and different systems with the different types of support are going to be very useful, and we have to wait and see how that will unfold. But thank you for your time. I really appreciate the honor to be here and to talk to y'all, and I'll turn it back over to the moderators. Thank you.